I'll be dealing with this topic, that is WHO pain ladder and its relevance in modern cancer pain practice. It is more than a study or anything. It has been the work experience in this particular hospital of mine. So, without further ado, first of all, greetings from our institute, Sri Shankara Cancer Hospital and Research Center. Let me start with this, I won't say story, an actual incident. If I could narrate it, kill me were his words of a patient suffering from CA rectum who was post-surgery and post-CTRT. Intractable pain made him feel that his life is not worth living as he was completely bedbound. Only hope were strong NSAIDs which had driven his RFTs to the virtual edge. He was an ex-policeman asking me to end his life. Of course, legally I could not. So I told him I will fulfill his wish, but to give me 2 to 3 weeks time to try some other step 3 medications, or if not any interventional procedures, and with the importance of management of total pain, which we've already been spoken about today. Every medication was tried, but to no good. Eventually, I had to try invasive procedures. He underwent the SHPN with ganglion implant neurolysis. 2 weeks down the lane, not very happy with the results. Finally, ended up with an epidural injection with catheter insertion with an elastomeric pump. Yes, this topic, anesthesiologists, please be with me. It's very interesting. 2 weeks after that, I had literally forgotten him. And in the OPD, a gentleman walks in with fresh new clothes, hair dyed completely black, almost ended up asking who he was. It was the same patient who had come for a refill of the pump. After attending a function, riding his motorcycle, he said, "Can I keep this forever? The catheter and the pump." I said, "No, I have strict protocols to follow." And he was unhappy about that decision, about that advice, what I told him, since he was not on any other medications and he was totally pain-free. A walking patient who was totally bedbound. Eventually, he ended up with 3 such epidural insertions around a gap of 3 months. So for the total of 9 months, the most important line is down there. He had a peaceful death at his residence with his family members, pain-free. So, I'm not able to change the slide. Can I do it manually? Is it okay? Okay. So what are we talking about? The magnitude of the problem is here that 40% die with severe pain. 60 to 80% complain of inadequate pain relief by their physician. 15 to 20% are not relieved by any drug treatment alone, so end up requiring interventional pain management. So we have these various therapies as the patient progresses in the disease, that is the disease-directed therapy, patient-directed therapy, and the family-directed therapy as a part of the palliative care protocol. So let's focus on the disease-directed therapy. So what are the reasons of the pain? They can have procedural pain, treatment-related pains, pain of the metastatic disease, and pain at end of life. And that is because we have something called as survivorship, that is long-term survivors. Why? Because we have to thank the medical advancement in the medical treatment of cancer. So that it can be from remission to cure or remission to relapse, but still it will be taking a lot of time, and there will be pain in these long-term survivors. So I'm talking about those kind of patients. So classically we have the WHO analgesic ladder for cancer pain management with the 3 steps initially, and then modified to have the 4th step, which involves the interventional treatments and so on and so forth. So what are these interventional procedures? These interventional procedures are minimally invasive techniques aimed at alleviating pain. They include injections, nerve blocks, implantable devices, or other minimally invasive procedures offering targeted relief for patients with chronic cancer pain. In this photograph, you can see in the slide, you can see that this is the ganglion implant block, and this is the fluoroscopy guided celiac plexus block. And here we have an ultrasound guided procedure being done. So it can be either ultrasound or fluoroscopy or combine both, what we call as a hybrid technique. So we have here, you have the SHPN, that is a suprahypogastric plexus neurolysis, fluoroscopy guided. This is the one I was talking about, the hybrid intercostal neurolysis, where we use the fluoroscopy as well as the ultrasound. And this was another interesting case where intractable pain, where we are doing ultrasound guided pulsed radiofrequency ablation of the median nerve. Who are these cases? So these cases are, when I presented this in a tumor board, I faced a lot of negativity there, because they were saying bone pain, okay, let's give radiotherapy. Why wasn't radiotherapy discussed? But I was very, I didn't want to tell them that all these cases, these are the cases called as the so-called burnt out cases. Every possible modality has been tried. From the medical oncologist, surgical oncologist, or palliative physician, whoever it is. Every particular modality was tried. When it failed, they still had severe pain. What happened? These are the next few slides about certain cases which are very interesting and how we managed it. So this was a 65-year-old male patient, multiple myeloma, bedridden with moderate to severe back pain. Stopped going to his job because it was involving a lot of sitting, and he was unable to do that. So with the initial metabolic workup with blood tests and correction, still mid back pain persisted. Then we asked for an MRI. What does it reveal? It reveals a L1 fracture. And most important here is clinical examination. Does the pain generator correlate with MRI findings? So he had the pain at the back, at the site where the L1 fracture was there. So after due discussion with the patient and bystanders taking due consent, this is me performing the percutaneous vertebroplasty in this patient. So post-procedure, the beauty of vertebroplasty is immediate relief. You do the procedure, you remove the needle out, the patient has good pain relief. So from 10 on 10, it came to 2 on 10, 2 by 10, and I don't have his photos. He had shared a lot of photos of him riding the motorcycle and sending me a lot of audio clips praising me. Sir, you did that procedure, you did this procedure. Now I'm in Dubai, I'm attending functions, I'm doing that, I'm doing this. So again, today's whole topic, from the first topic what we heard, it's always about assessment, reassessment, being with the patient. It may be very difficult. You may not have the skill set to do it, but there are people who can do it still. So it's about right referral and right choice of treatment for them. So there is always focus on finding the pain generator. That is what I'm trying to tell. So here we have another female patient, 39-year-old, with recurrent CA breast. Surgery was not possible, and you can see the pain that was involving the arm, whole of the right hemithorax, part of the shoulder and the neck. So we tried all possible medications, like step 3 was completely, we exhausted it. Still there was no relief, absolutely no relief. And I had to finally go and do an interlaminar cervical epidural catheter insertion. It's been 1 month. The catheter is still there, and she's with the pump. We are still continuing the medications. And did it give it any relief? She says about 60%. So from 10 on 10 or maybe 100 on 10, it has come down to 4 on 10. This is the quality of life we are talking about. So how are we be able to do, of course, quality of life or quality of death, I leave it to you to decide. So another patient, 56-year-old female patient, CA breast, post-treatment, severe mid-back pain, NRS 10 on 10. The only position she was able to lie down was flat. She could not turn even an inch to her right or to the left. She came to me with complete agony. So we did the initial medications and everything. Nothing was working. Again, we did a MRI. Again, it revealed a vertebra plana fracture. This is one of the most complicated fractures in the mid-thoracic region. So me, along with our very good interventional radiology team, we did a CT-guided kyphoplasty. So I'm happy to announce that in Shankara, we are doing much advanced procedures. CT-guided, we are beyond fluoroscopy and ultrasound. Now it's gone to CT-guided procedures. I'm very happy about it because it is helping patients. It's not that we are praising that we are able to do it. No. If it is helpful, why not? So immediate post-procedure was NRS was 0 by 10. Follow-up remains the same, alongside with, of course, not to forget the metabolic component like disease modifying and bone strengthening measures. So another patient where 55-year-old multiple myeloma, severe pain, low back pain, which was affecting her daily activities, including sleeping, sitting, and so on, was put on fentanyl patches as for the severe pain, whatever. And see, your practice is restricted by your institution, by what you have. Some people may not have patches, some people may not have tablets, medicines. So it is restricted to individual practice and institution practice. I do agree. So in our practice, we went on with the fentanyl patches up to 75 mcg. Patient bystander somehow landed up with me asking, sir, pain ella okay, sir, but patient is completely sleeping. What do I do with this patient? So we thought of, okay, let's evaluate, and further we did MRI and found out that there is CT and MRI. We found out that there is some sacral insufficiency going on. So we did a CT guided. This is the CT guided sacroplasty. Post procedure, she is back to her daily activities. Continues to be in follow up, and those issues are not there. But cancer patients are very difficult. You treat one site, another site crops up. That is always there. So reassess, be with them. So that is very important. Unfortunately, I don't have any images of this patient, but I had to tell about this patient who was a chronic tobacco chewer, 75-year-old gentleman. Each case is one, I can say, a novel on its own. This patient just could not sit, not even for 2 minutes. And you won't believe, for 1 month, he and his family, both of them were supporting him. They were also throughout night standing with him. So who was suffering? Not only the patient, it's the entire family. So finally we did evaluate him. So he had some issue with the insufficiency of the ischemium. CT guided ischemoplasty was done. NRS became 0. He died in front of me 2 weeks later. He told the family, I want to meet that doctor who reduced my pain. Please take me to him. I am not boasting about myself. He came. I saw him. 20 minutes later, he just fell, and in front of me, he lost his life. But I was happy that at least he was pain-free. So what am I talking about? I'm just blabbering over here my own personal experience, or is there any evidence over here? Okay. So we can see that the interventional therapies are important to consider when facing cancer pain refractory to conventional therapies. The objective of the current review is to introduce these effective strategies into dynamic interdisciplinary pain management, thus leading to an exhaustive approach to supportive oncology. Between 10 to 20% of patients with cancer pain cannot achieve adequate control following 3-step ladder guidelines of the WHO organization. Therefore, a 4th step, including interventional approaches, has been suggested in those cases. However, systemic reviews support the early use of these interventional procedures to treat refractory cancer pain, control symptoms, and prevent opioid dose escalation. There is strong evidence for all these procedures. Those procedures have been found to be associated with decrease in symptom burden and opioid consumption, improved quality of life, suggested as having a potential positive impact on survival. Isn't that what we all want in those patients? Correct? So, invasive interventional procedures for managing pain in cancer patients are often underutilized following the popularization of the WHO analgesic ladder. The procedures that were successfully used until then were relegated away from mainstream palliative care practice with the advent of newer opioids and adjuvants. Even though nerve blocks, intrathecal pump, spinal cord stimulation were reintroduced as a 4th step of ladder, often referrals for these procedures are too late to produce a meaningful effect on quality of life. At this point, most patients have advanced disease and are requiring end-of-life care. So, additionally, it is becoming evident that at least 10% of the patients do not achieve good quality of analgesia with oral opioids and are often troubled by unacceptable side effects. So, this is the Indian paper with that. So, we did a lot of procedures, all right. But I am happy to say that not in a single patient, totally around 150 to 160 procedures so far in the past 2 to 3 years, not even in a single patient the protocol was broken. That all step 1, step 2, step 3, you reach step 3, it's not happening, then we are thinking about a interventional procedure. So am I just telling about it, or did we have actually evidence? We have worked out something like the PROM as a part of the audit, internal audit in the hospital. I'll brush through that. So PROMs are a pivotal role in assessing the effectiveness of interventional pain procedure. Not only interventional procedure, any procedure what you do, you can do a PROM. So what was done? this was a bit back, so we had 117 patients with the data from 2023 to 2024. Pre-pain NRS and post-pain NRS was recorded 1 week, 1 month, 6 months, and after the procedure. So, our highest cancer pain pre-procedure was elicited in CA pancreas, cancer mets, spinal and bone mets, perianal pain in CA lung, CA rectum and CA lung. So these three, remember this. I'll come back to this at the end of the discussion. CA lung, CA pancreas and CA rectum. Okay, it was found that it's very difficult to, they had a very high pre-procedure NRS. So procedure with best results are these, but I'm not going to discuss this. I want to discuss the failure. I want to discuss my failures and why did it happen. So you can see that again, these are the same three places, that is CA pancreas, CA lung and CA rectum. Okay, so the pain generators are very extensive in these patients. So what did we do that? We learned from it. We changed I changed my technique. For instead of celiac plexus, why not do a splanchnic neurolysis or a splanchnic block for CA pancreas, right? So that was the whole purpose of this study which we did in our institution. What happened? Definitely there was significant differences between the pre and the post NRS. So there is that means the interventional procedures had a positive impact. So now, is there a need to alter the WHO ladder for certain conditions causing cancer pain? That is the question I want to ask, and I'll answer that. The need of the hour is a more comprehensive model of managing cancer pain is needed, that is mechanism based and multimodal, using combination therapies including interventions when appropriate, tailored to the needs of an individual with an aim to optimize pain relief with minimization of adverse effects. So again, it's your responsibility. Doesn't mean I can do a procedure, you do a procedure. No. Clinical evaluation, proper precision, proper consent, everything has to be strictly ethically followed. So I would like to conclude with that a pain generator can be a non-malignant source even in a cancer patient with advanced disease. Early intervention is the key to reduce morbidity in CA pancreas patients, CA lung having pain, to involve them actively early in the disease treatment, because as the days progresses, as the years or months pass by, pain becomes very adamant to every possible treatment, especially the neuropathic component. Pain management with understanding of the total pain concept. I am not saying only intervention, no. Always, it's a total pain concept. Has to be borne in mind, is vital to manage pain and reduce morbidity. Interventional pain procedures play a pivotal role in selected patients in reducing morbidity in patients in the palliative phase of treatment as well. And most importantly, quality research is needed in the field of interventional cancer pain management to investigate the existing protocols. There are studies saying that we should discard step 2 completely. Have 3 steps, step 1, step 2 and step 3. Step 3 involves interventional pain management. Mild directly go to severe. So all these things are there, but it cannot be just personal experience or a personal talk or an opinion. We need good quality research in this field to investigate the existing protocols. This has been the way I note down my studies, the procedures. Thank you.
Yeah.